Cultural Context of Health project. Now, a key part of this project is to demonstrate why recognition of the cultural context of health actually matters in terms of understanding health and well-being, and to find ways of then effectively responding to people's subjectively defined needs and priorities. And a key part of this, of course, involves looking beyond some of the more conventional biomedical scientific approaches to extend what we mean by evidence, to think about what humanities and what social sciences can actually add as well to help inform health-related policy. Absolutely delighted that our first speaker today is going to speak directly to all of those themes. So Mark, hand you over to you.
Thanks, Felicity. It is a great pleasure to introduce our speaker today. There is a reason, in fact there are a number of reasons why we have chosen Jeremy, why we've invited him. The first is that in many ways he has an identity crisis that embodies everything we are trying to encapsulate. That is, he has double qualifications as a physician and as a historian, continues to practice in both domains in a community health center in Baltimore, as well as publishing extensively as a historian. And in many ways, what we're trying to do in the WHO Collaborating Center and the Wellcome Center is precisely to bring these perspectives together to develop new ways of understanding health, new ways of addressing health issues, and new ways of engaging with policy, and that's another dimension of Jeremy's work. So he embodies the hybridity, the connections, the complexity that we're trying to capture in the WHO work and the new Wellcome Center. The second reason why Jeremy is important to launch our series is because he has an interest in global health and global health history, the interconnections between parts of the world. Some of you may have seen an article in The Lancet recently that Dora and Jeremy published, which is a really interesting story about diphtheria antitoxin. The fact that in some parts of the world, many parts of the world, diphtheria is curable and in fact largely eradicated. Great. But what that meant was that there was no market for diphtheria antitoxin, which meant that production stocks declined, so that when diphtheria did emerge in some parts of the world, the capacity to respond to that was diminished. Now, the important point of that, of course, is that no part of the world is disconnected from other parts, and there is a political economy, a market that shapes the ways in which certain parts of the world are able to respond to health challenges. And it's that sense of the global, that sense of the interconnectedness of domains, parts of the world, that matters to us in the WHO Center, but also in the Wellcome Center. The third reason, and it comes out of that work in particular, Jeremy's work covers the history of prescribing, the history of generic drugs, as well as new projects on technology and medicine and the way in which that reshapes healthcare. The third reason, though, for me, and this is, I think, again, this is crucial to our formulation of the centers, is that there is a strong sense in Jeremy's work of social and political justice. That if you read the work on diphtheria antitoxin, the ways in which markets sustain particular networks of power, then that is at the heart of Jeremy's work, but it's also at the heart of ours, that we want our medical humanities, social science work to engage with real-world problems about health inequalities, the distribution of resources, and the ways in which we can work collectively to enable health. So I think that's a very strong feature of Jeremy's engagement, and of course, in some ways, that emerges from the hybridity of his experience in his career, that he is working in different dimensions, different domains. The final point, and Felicity alluded to it, is that Jeremy is also committed to engaging with policymakers and policy debates. Part of the rationale of the Wellcome Center and of the WHO Center is that we work beyond the academy, that we work in a transdisciplinary way, not just talking to ourselves, but engaging in policy and practical debates, contributing as historians, as social scientists, as geographers, anthropologists, to debates about how we enable health in the modern world and how we address social and political injustice in terms of health inequalities in particular. So in all those ways, Jeremy's work is central to the kind of vision that we have for the WHO Collaborating Center and for the Wellcome Center. So it's a fantastic pleasure, Jeremy, to introduce you and hear you.
Okay, thank you. Thank you so much for that generous introduction, Mark. And it's really a pleasure to be here. And let's see, I think we've got the technology mostly set. I'd like to also address the audiences that are not in this room right now. And again, I'm looking forward to the questions that come from afar as this manifestation of the University of Exeter's Cultural Context of Health programs, and particularly in this new role as a collaborating center for the World Health Organization program on culture and health. And I have to say, oh, let's see, we're now projecting this control panel. Yeah. This is inevitable. This is sort of this kind of Icarus-like flying too high on these technology here. Let me actually, I'm going to exit this for a moment. I don't seem to, oh, there we are. I can grab it, pull out the offending window. All right. Let's make it go down there. All right. I realize that those of you you're all looking at the top of my head now rather than me. But here we go. Anyway, I'm especially pleased to be here. Really, in this spirit of interdisciplinary venture with such a fine group of scholars doing important work at the intersection of the medical humanities, the social sciences of medicine, and the fields of health policy and clinical practice. And I'm particularly thankful to Dora Varga, and as Mark mentioned, I've already had the pleasure of collaborating with Dora on this diphtheria story, which I'll mention just a little bit more at the beginning of this lecture. And this began innocently enough over a conversation at a conference on the multiple meanings of translation in medicine a few years ago. And in the course of this conversation, we realized that our own work, even though it was in very different places within the history of medicine and global health, had led us to recognize the value of translating historical experience, and particularly historical analysis, to broader audiences in present-day medicine and public health. And of course, this sort of thing, saying that history has value in present-day policy and practice, immediately raises red flags for some historians. And on the one hand, there's a risk of being seen as an advocate or an activist instead of a scholar. Engaging with policy can be seen to risk the objectivity of a historian as a social scientist. On the other hand, there's a risk of being seen as a presentist, and many in the room will know this word as the horrible epithet that it is among historians. It's a terrible insult, and it suggests that engaging with the present can limit the ability of a scholar to understand the past in its own terms. And on some level, one whole justification for the value of historical analysis is to appreciate the past on its own terms, not in terms of the categories that we know and think and use. And I think we can demonstrate these two risks are largely paper tigers. After all, what scholar doesn't engage in some advocacy on some level, even if it's only just for themselves or their family? On the other hand, all of us live in the present, and this present affects the kinds of questions. Part of the nature of historiography, of understanding how different historians of the Roman Empire at different moments in time since then ask different questions because of what becomes visible to them because of the present that they're in. So there are forms of presentism that we all must celebrate as well. But there are reasons to be cautious in these waters all the same. And these risks and rewards, this is really what I'm here to talk about. Now, I'll start by describing this piece in The Lancet, and a piece on what we call gray market medicines. And it concerns the eroding presence of old but effective drugs, and asked what history has to tell us about how we forget and how the infrastructure of biomedical science and industry and practice can decay as well as grow. And we started with a simple question, which I'll pose to you as an audience. If you were to contract the dread disease diphtheria, when would you be more likely to survive? In 1916 or in 2016? And a show of hands here. How many would rather be diphtheric in 1916? And how many would rather be diphtheric in 2016? And so, okay, so we have maybe an 80-20 split in the audience. And now, in 1916, there was a lot of cause for enthusiasm if you happen to be a patient with diphtheria. Now, I expected some of you to ask me a question back and ask, well, where? Because the where of that when has a lot to do with both 1916 and 2016. But if the where is, say, Toronto, here's a display from the Toronto Provincial Board of Health and the University of Toronto Antitoxin Laboratory from 1916, celebrating not only the invention of the diphtheria antitoxin in the 1890s, famously by Emil von Behring and Emil Roux, but also the broad, Emil is a fantastic name, also the broader success at disseminating this innovative therapeutic for free to the Canadian people. And here you see this kind of genre of public health display. And I don't know if you can tell from where you're sitting, but what you're looking at is effectively a graph of the mortality rate from diphtheria in the pre-antitoxin era, which is in black, and then the post-antitoxin era. And like all graphs, like all visual displays of quantitative information, this makes an argument. So what's the argument? I caution you not to overthink it in this case.
Diphtheria antitoxin lowers diphtheria.
Exactly. So here's a heroic response, right? That we see a decrease in mortality rate from diphtheria because of this new biomedical therapeutic and its dissemination for free through a viable public health system that can make this available. Not just the innovation, but also the dissemination. And what I want to point out, perhaps it's harder to see from where you're sitting, but that this decline is literally being recorded in boxes of diphtheria antitoxin. So this display is constructed of vertical stacks of diphtheria antitoxin. And we're familiar with this kind of historical narrative. This is a historical argument being made here, graphically. And it's a narrative of progress, of perhaps radical change, of a new post-biomedical era which can be seen beneficially in a shift in quantitative displays of mortality information. Paradoxically, though, the future for diphtheria antitoxin will be clouded by another pharmaceutical product, which is the widespread adoption a few decades later of the first successful vaccines against diphtheria. So and here is a display of the diphtheria toxoid vaccination. And efforts in preventing diphtheria eventually become so successful, as Mark suggested, that markets for the cure for the disease, that is the antitoxin, dwindled and failed in most industrialized nations over the late 20th century. By the 1980s, a once thriving North American diphtheria antitoxin industry dwindled to literally nothing. In the US, by the 1990s, not only was there no North American production of antitoxin, but there were no overseas products that had been cleared by the FDA anymore for the American market. And in the increasingly rare cases of clinical diphtheria, doctors would have to use an unapproved form of the drug manufactured in France at Pasteur-Moreau. By the early 2000s, Pasteur-Moreau also shut down production, and in the US, stockpiles of the drug instead came from a Brazilian manufacturer, Instituto Butantan. And keep in mind, by the 21st century, diphtheria antitoxin becomes an unapproved drug. And so let's say in my clinic in East Baltimore, I were to see a patient who I suspected having a clinical case of diphtheria next week. I would need to fill out an FDA 1572 form so that I could be listed as a clinical investigator working with this unapproved new drug in a regulatory sense, regardless of the fact that the drug itself predated the 1906 launch of the Food and Drug Administration to begin with. But it becomes recoded as a new drug, which creates new forms and barriers and hurdles to actually supply to patients. Now, similar problems can be traced across Europe. I'm not going to sketch out the contents of our whole article, but we've seen 2 deaths from diphtheria in the past few years in Spain and in Belgium. These casualties remind us of the human costs of neglecting older drugs, or of acting as if the biomedical infrastructure that we have produced in the past up to the present merely reproduces itself or maintains itself. And what I'd like to do in the rest of the talk today is to talk about this problem. How does an old drug like diphtheria antitoxin become new again? How is it that our relentless focus on innovation and the histories we tell ourselves of biomedicine occlude our ability to focus on the importance of maintenance and the importance of thinking of the problematic decay of vital aspects of biomedical infrastructure built over the 20th century that are now crumbling? What is being lost in the uncritical histories we tell ourselves every day in order to act in the present? And what can the historian of medicine offer to current policy and practice? And so in the time that I have left, I want to do this in 3 sections. I want to explore a few more problems of the rejuvenation of old drugs, and I'm going to focus on North America here, although I hope to sketch out some of the global connections that Mark pointed out as so vital. First, to briefly demonstrate that historical analysis is always present in the arena of health policy. The question is, is it good historical analysis, or is it very thin, uncritical historical analysis? Second, to explore how closer engagement with what historians bring into the picture, what a cultural history, what a social history of medicine brings into the policy arena, beyond simple teleologies of innovation. And then finally, to generalize from some recent experience of my own attempts to engage in clinical and policy audiences, to ask what happens when historians and other scholars from medical humanities and social sciences of health engage outside of the academy in fields of policy and practice. And again, I want to stress that there are risks to this engagement, but also rewards. So to begin with this problem of uncritical histories, as a card-carrying historian, I see history everywhere, and that may be a matter of professional self-interest. I can't move beyond my own sense as a stakeholder here. But I don't want to just suggest that every moment we live in becomes some historical record for the future, but that every newspaper article, every journal article, every deliberation in Congress or Parliament or the World Health Assembly rests on certain modes of mobilizing the understanding of the past to inform the present and project towards the future. And this is not itself a problem. Obviously, as a historian, I want to continuously emphasize this is part of the relevance of history and policy and practice. But the trouble is that many of these modes of interpretation rest on cliched or melodramatic narratives. The wonder drug, the rising star, the corrupt executive, the experiment gone awry. The business of journalism about science and health requires preformed narratives to be reproduced. In order to sell an article to an editor, a journalist needs to package it. And these narratives oftentimes reproduce their own structures and produce their own cycles. You can trace these same kind of narratives backwards over time. There are only so many kinds of stories a newspaper can tell. And again, this has been true, this can be traced over the 20th century very easily. So I can offer you a few examples from my own field of study, pharmaceutical history. Some of this has been well narrated by other scholars. I'd point out, for example, Dominique Tabel's book, Pills, Power, and Policy, which traces the continuity of a series of congressional investigations into pricing and marketing strategies of the American pharmaceutical industry. She traces it from the 1950s to the 1980s and shows the continuity of certain narratives within the industry and their political mobilization and the success of that mobilization. So here's the first widely publicized set of hearings into the marketing practice of the pharmaceutical industry. Takes place launched by Tennessee Senator Estes Kefauver in the late 1950s, spilling into the early 60s. And much of the debate in Kefauver's hearings revolved around historical interpretation of a therapeutic revolution, a very important framing, the idea that the American pharmaceutical industry had caused a therapeutic revolution that supposedly took place in the mid-20th century. So here on the left, we have the Secretary of Health, Education, and Welfare, Abraham Ribicoff, testifying in front of Kefauver's committee that there has been an amazing revolution in the drug field in the last 2 decades, quote, that has contributed enormously to combating ill health and has been a major factor in the dramatic advances of medical science. In that time, Ribicoff argued, life expectancy had gone up, death rates from infectious disease had gone down, many chronic diseases had been made newly manageable. And Secretary Ribicoff warned of the drug revolution's negative side, however, planned obsolescence, trumped-up claims of Me Too drugs, brand name monopolies, extravagant advertising and promotional campaigns, patenting practices that contributed to the higher and higher prices of drugs in the early 60s. But if all drugs were merely snake oils in updated packaging, marketing would be simpler to regulate. But Ribicoff had a problem that complicated by the fact that some of these new drugs were dramatically effective, could produce significant mortality and morbidity shifts. They had a power to alter the balance of life and death. And so current pharmaceutical marketing to Ribicoff became a problem precisely because, quote, they have contributed to an unreasonably high cost to the consumer for many drugs which are essential to the maintenance of health and even life itself. So the very power of these revolutionary new therapeutics turned inequity of access into a moral problem for American society. Now, the narrative of the therapeutic revolution, I've just shown you a mobilization of this narrative by critics of the marketing practice of the pharmaceutical industry in the early 1960s. But it was used far more successfully by the industry itself to defend those marketing practices. So as in their repeated trips to Capitol Hill in the 1960s to testify in Kefauver's investigations, and then subsequent investigations by Senator Gaylord Nelson of Wisconsin, Pharmaceutical executives regularly invoke narratives of the therapeutic revolution to explain why antibiotics, anti-tubercular agents, psychotropics, anti-diabetics, and other new drugs in the mid-20th century had transformed the epidemiological, demographic, and economic profile of the United States. As SmithKline's Walter Munns testified, this historical framework of a revolution was crucial to defend the high prices of on-patent prescription drugs. Each executive invited to speak before the panel, as well as the head of the pharmaceutical lobbying group, the PMA itself, emphasized this narrative of rupture with a pre-modern past brought by the pharmaceutical industry, in which a therapeutic revolution allowed the American pharmaceutical industry to effect radical benefits for American society in a short period of a few decades. And I want to point out here that this historical narrative of the therapeutic revolution celebrated the industry as exceptional, an industry that state regulation should not touch, and to that effect, it was a very successful historical framing. Kefauver's original bill, his original piece of legislation, sought to reduce the approval of new drugs only to those who proved that their new agents were better than existing remedies. He sought to eliminate pharmaceutical brand names outright, to reduce the patent life of drugs to a 3-year patent. And this bill that he proposed was thoroughly gutted at the hands of a very successful lobbying effort of the industry itself, which leaned on this historical narrative. So I'm trying to suggest in one way that history was essential to the forming of pharmaceutical policy, although not in the ways that we had necessarily recognized initially as historians. Now, the remnants of Kefauver's bill, and some of you in this room may know of the Kefauver-Harris amendments that passed as a result of these hearings. What they do is they become instrumental in establishing a new era of pharmaceutical regulation in the United States based on adding proofs of efficacy, specifically randomized controlled trials, and the concretization of what we've now naturalized as a 3 or a 4-step set of phases of trials that drugs need to go through before they're approved for use: phase 1, phase 2, phase 3, and phase 4 once they're in practice. So what happens after the Kefauver-Harris amendments are passed? And I want to suggest Kefauver-Harris amendments do almost nothing to address issues of pharmaceutical pricing. In fact, one could argue that by narrowing the gatekeeping function of the FDA and extending the protection of drug monopolies, they encourage the increase in pharmaceutical prices for on-patent drugs. Also by lengthening the amount of trials that need to go in before a drug is approved, that this sequence now becomes a crucial part of a justification for why pharmaceutical prices need to be as high as they are. So what happens, how does the historical narrative of the pharmaceutical industry shift after the passage of the Kefauver-Harris amendments? And in subsequent decades, these amendments become part of the new narrative mobilized by the lobby, which is a narrative, I would argue, of historical trauma and decreased innovation. So in the early 70s, William Wardell from the industry-funded Center for Drug Development publishes a study of the number of new drugs approved by the U.S. Food and Drug Administration since 1962. And Wardell laments the damage which these new protections had caused to the innovative character of the American pharmaceutical industry. And what he does is compare pre-1962 drug approval rates with post-1962, but not only in the United States, but also with the UK and other European states, but particularly the UK. And from this comparative historical perspective, Wardell offers a historical framing of what he calls an American drug lag, in which American consumers are now seen to exist in a temporal space some years behind the UK and other European countries, which get to benefit from new drugs quicker. And this analysis is rife with assumptions, for example, that all new drugs are valuable, that they're all not harmful, that the American public would be better off with access to more unproved therapies. They get rolled in under the metrics of how one measures innovation. And innovation is simply a drug that is approved. That is a good thing, and it is a problem that innovation has been declining. Nonetheless, it was a highly effective rhetorical form. And if you track the history of the drug lag debates in US pharmaceutical policy, they build over the course of the 1970s, ultimately leading to a successful bid by the industry to lengthen further the length of patent protection afforded to new pharmaceuticals, and therefore actually the length of monopoly period through which very high prices can be charged for new drugs, seen as necessary to further increase the innovation that has been damaged by the existence of these efficacy requirements. So, and these efforts are ultimately successful by the early 80s and rolled into what's called the Hatch-Waxman Act, which further extends patent life of pharmaceuticals. Now, in the 1990s and 2000s, a related series of historical arguments are made by industry lobbyists to protect drug regulation and to ask for further extensions of patents and other marketing exclusivities. This includes a series of graphic visualizations of productivity over time, prominent in the construction of a new historical narrative of the productivity crisis in the pharmaceutical industry. And you've probably seen some version of these graphs in one or more clinical public health policy or popular presentations. In this account from Ian Cockburn, it maps out the decline in the approval of new drugs in relation to increased spending on pharmaceutical research and development. Seen as a paradox, how is it that with more and more money being spent on pharmaceutical R&D, fewer and fewer new drugs are approved? This, again, is mobilized not only to argue in the US for extended and multiple patent marketing exclusivities, but also to further justify why new drugs need to be more and more expensive. As the productivity decreases, the policy justification for more exorbitant pricing also increases, and it does an important form of political work. Here we see another visualization in which the graphing is not linear but logarithmic. And again, like any data visualization, so we'll think back to those stacks of antitoxin boxes. This chart makes an argument, but it's an argument that's both historical and extraordinarily thin. It's a very decontextualized view of history. So now, again, we've established you're a clever bunch, adept at reading historical arguments. So what's being argued here in this graph of the productivity crisis? So here, I'll narrate it as well for our audiences, our virtual audiences. On the x-axis we have time from the 1950s to the 2010s. On the y-axis we have the number of drugs approved by the FDA per $1 billion in U.S. R&D spending. And there are a few bits of text on there. The FDA tightens regulation. First wave of biotech. FDA clears backing. What is the visual argument being made here?
More regulation leads to fewer drugs.
So we would think so, right? More regulation leads to fewer drugs. But actually, they're arguing the opposite. And so why might they be arguing the opposite here? So, here I would say that this graph is similar in its purpose as a historical statement to, say, Thomas McCune's graphic visualization of TB mortality decline in arguing for the irrelevance of biomedical interventions. Because you see here, graphed here, a slope of this decline. And that slope is constant, right? So that regardless of the FDA tightening regulation post-thalidomide, regardless of the first wave of biotech-derived therapies, regardless of the prescription drug user fee amendments, that's what PDUFA stands for, the slope remains unchanged. So the authors of this article are arguing something very different, which is that this is a natural progression, that somehow what they're observing is a law of declining innovation in the pharmaceutical industry, similarly built to produce a justification, right, for why more money needs to be charged for new drug products, but at this time being disengaged from an argument of regulatory happenings and instead being rolled into the natural life cycles of drugs. And I want to come back to this because how many of you have encountered Moore's Law? A show of hands. So, Arthur, what's Moore's Law?
I got Moore's Law, justice. Are you talking about Moore's Law or Moore's paradox?
Oh, sorry, Moore's Law. So it's not fair of me to ask the audience to do all the work, but so Moore's Law within the field of technology and specifically in processors has to do with that there's a constant time that is required for observing the doubling of how many transistors can fit in an integrated circuit for the same price. In other words, it's a measure of the innovation of the computing industry that has been naturalized. And this is why the computers that I used in high school are several of them can now fit inside of my telephone right now. That there's sort of a natural progression of innovation in these spaces. And what the authors of this article dubbed Eroom's law as an inversion of Moore's law, it's literally Moore written backwards, is that exactly the inverse can be seen for the natural fate of the pharmaceutical industry, that somehow there are a set of forces that are driving the industry to become less and less and less innovative over the 20th century. Now, I want to suggest that therapeutic revolution, drug lag, productivity crisis, these are all historical arguments. They're decontextualized, they're thin arguments, they're teleological. They support structures in the present day, they naturalize them. And they're highly successful at engaging stakeholders in American pharmaceutical policy, arguably much more successful than we are generally as historians. And I want to reiterate here that historical thinking is not absent from the political realm, but the kind of historical thinking that succeeds in policymaking tends to be thin. It tends to be teleological and more generally focused on questions of innovation than questions of access. So too we find in the vaunted 21st Century Cures Act, which a bipartisan bill passed in the final hours of the Obama administration. And in the work going up to building this 21st Century Cures Act, which privileges new forms of innovation by lowering thresholds for drug approval and by producing new forms of funding for the NIH, a lot of the work behind it involved certain forms of forgetting. It almost exclusively focused on the promise of new medicines to come, and not at all on questions of how to maintain the safe and affordable provision of 20th century cures to a population increasingly unable to access them. And here we see some of the arguments back and forth by, actually by some of my former colleagues at Brigham and Women's Hospital, pointing out that embedded in the language of the 21st Century Cures Act are some good ideas that could streamline the development and evaluation of new drugs and devices. Its call for increased NIH funding may prove to be its most useful component, but political forces have also introduced other provisions of the drugs that could lead to the approval of drugs and devices that are less safe or effective than existing criteria would permit. And effectively, they point out that instead of catapulting us into the future, it could actually bring back some of the problems we thought we had left behind in the 20th century. So one of the problems in trying to engage as a historian with the 21st Century Cures Act, and I spent some time going to Capitol Hill and participating in briefings with congressional staff members, is that nobody wanted to hear about 20th century medicines. I was continuously reminded this is a 21st Century Cures Act. This is not about making the drugs we have already accessible. So one of the questions I have as a historian, as someone committed to this problem, is how do we use tools of historical analysis to make the problems of access of existing drugs undeniably present? So I want to turn away for a moment, though, from these kinds of histories that policymakers prefer. We can label what have been some successful strategies for using historical narratives, certainly on the part of the industry. And we can label some of the problems that we might have with those historical narratives as historians, but that doesn't give us the answers to how to actually put them together and find that site of engagement. Now, I want to think, again, about the importance of the center and the seminar series that we're launching today, of insisting on the value of close analysis of social and cultural context, that social and cultural historians, as well as colleagues in anthropology, sociology, philosophy, and other fields of medical humanities can bring to the table. And again, I want to say that's all well and good within the academy, and certainly within a center like this one. We do a very good job in our journals and our scholarly meetings, but how do we translate what we do into terms that influence policy and practice as well? And I've been thinking about this a lot this past year. I'm going to offer you 3 small stories here. My own work on pharmaceutical history may seem immediately, just in saying the phrase pharmaceutical history, may sound like it's relevant to policy, but it didn't start out that way. And it started out with a suspicion that the historical narratives that we've been telling ourselves about the value of generic drugs, for example, and our suspicion of brand names and marketing were missing something very important, that the kind of narratives that we have when we talk about drug policy actually miss vital things. And I'll give you a brief illustration of this. When I was beginning my PhD, a study was published called the ALLHOT study. And this is a long acronym, not as long as some, but it stands for Antihypertensive and Lipid-Lowering Treatment to Prevent Heart Attack Trial. Now, I don't quite know how that comes down to ALLHAT. I think if you were really to pronounce all of the words, it would be ALLHAT. I think it would end with some kind of untenable diphthong. But ALLHAT was one of a very small number of publicly funded clinical trials that compared a series of then expensive brand name drugs for hypertension, calcium channel blockers, against a generic sort, a thiazide diuretic. And the initial findings indicated that cheap older drugs were every bit as good, perhaps better in some ways, than the newer expensive brand name drugs. And this was, of course, a useful sort of knowledge for providers and healthcare systems and payers as well. And it fed into a common narrative of suspicion of the excesses of pharmaceutical branding and marketing. The older cheap drug was just as good, if not better, than the new expensive branded product. And at the same time, at the turn of the 21st century, we see a mobilization within the academy, within certain genres of journalism as well, of a growing critique of pharmaceutical marketers selling sickness in the terms of Moynihan and Cassels, which diseases like mild hypertension or mild diabetes or mild depression, which hadn't been diseases at all 50 years ago, now drove pharmaceutical consumption and also drove perhaps the greater incidence of side effects. And many of these analyses focused on current brand name drugs. The current branding of medicines was driving the promotion of diseases with deleterious effects, both economically and physiologically. But if you turn back to Alhut, as a historian, I encountered a problem, because this cheap drug, this virtuous generic drug, which would be a virtuous drug in Moynihan and Cassels' account, it wasn't always generic, right? So as a historian, what is a generic drug? Well, it's typically something that once was branded. And like all old technologies, generic drugs once were new. When the first thiazide diuretic was new in 1958, it had a brand name, Diaril, and it was at the time the most expensively promoted drug in Merck's history. And here you see on the left one of the early gifts given by pharmaceutical sales representatives to sell the drug, the Diaril man. And I should have brought, I have one, I left it at home. I wasn't sure it would clear customs. But it's a desktop statuette. It's one of these pharmaceutical desk totems. And it fills about up to the chest with clear fluid, which actually is baby oil or mineral oil. And you can see the body is reduced to a series of organs relevant for hypertension and congestive heart failure. And there's a small cistern with an opening in the base. And so when you turn the Diaril man over, if you then write him, he starts off filled with fluid, and then you gradually watch the fluid drain from his body. And so performatively, he both indicates a certain approach to patienthood and how to see a patient's body in terms of the drug, and also demonstrates the action of that drug. Now, as the advertisement on the right indicates, and the Diaril man became the omnipresent logo of this drug, this first thiazide diuretic, the clinical experience of physicians and patients and the clinical trials of Diaril helped redefine hypertension from being a disease of symptom, in which you could only have a disease of hypertension if you actually were symptomatic from it or had clear signs that were visible to the discerning eye of your physician, into ultimately a disease of number, in which merely having a blood pressure over a certain threshold could lead to triggering a guideline in which you would receive a pill. And these guidelines became the basis for actually judging the success of the Alhut trial itself. And so the brand, in its brand name incarnation, the thiazide diuretic helped to produce the category of illness that this later clinical trial of Alhut helped to justify its generic form as being superior, or at least equivalent to brand name versions. And so the historical complexity of this loop is actually really quite fascinating and informs a lot of our contemporary problems with medicalization in a way that simply denigrating the selling of sickness misses. Diaril is both brand and generic. It's both expensive and cheap if you look at different whens as well as wheres. The disease it treats is both a real public health concern and a marketing contrivance. It's both of these things. And so this was what drove the scholarship of my first book. I thought that was an important finding, and it led to the central argument of my first book, Prescribing by Numbers, which some of you will have seen. But it didn't really help to drive any policy. This kind of knowledge is not terribly helpful for building a policy, or for a politician to give a stump speech, or to use in negotiations with payers or manufacturers. It did two things that historians can always do, right? The first is to say, this thing you think is new is actually much older than you think it is. And the second is, this thing you think is simple, it's actually really quite complicated. Now, I do want to say that writing this book did help me as a clinician. And it helped me to understand the confusing space that patients as well as practitioners now face when clinical guidelines suggest their asymptomatic conditions need to trigger responses that lead to multiple medications, which can produce symptoms for the patient who previously had none. And it has also helped propel many conversations with other clinicians about the relevance of historical thinking, and especially historical epistemology in everyday practice. And for me, the value of this kind of history lies in its power to defamiliarize the conventional narratives at hand with which we can continuously explain the world to ourselves. In much the same way, and to actually problematize that these narratives have political and economic stakes, in much the same way that, say, therapeutic revolution, drug lag, and productivity crisis can be terms that become naturalized in policy and practice in the present. So having the skill to put a wedge under there, lift it up a bit, and understand what kinds of negotiations are at root, is really quite powerful. And also to approach our own taxonomies of disease and cure as something that rests in social and economic interest as well as biological fact. And to revisit prior paths not taken, solutions discarded, and pull them back into the present to help suggest things that are missing from our current conversation about policy and practice, even if it's not necessarily going to immediately change a bill being proposed in Congress or an action of the WHO in the present day. And this would be something which I think my own dissertation advisor, Alan Brandt, had described in an earlier work as policy relevant histories, that for the audiences that might be interested in such an analysis extend well beyond this room, extend well beyond this campus, and can lead to, if we can find the language to speak these findings and can actually emphasize the value of historical thinking to a broader set of actors. Now, this confusion that I found over Diaril, should we treat it as a brand name drug or as a generic drug, led to a more sustained interest in the generic drug itself. I couldn't get this out of my mind, that what I had thought was a stable thing, a stable and really quite virtuous thing from a public health or a clinical perspective, was actually a historically unstable and dynamic object. And I wanted to learn more. In the case of Diaril, shifting from being the poster child for expensive pharmaceutical branding to being a paragon of the salvationary possibility of generic drug utilization, drugs were simultaneously commodified and valorized as commodities when they got older, but valued in that commodity function of being interchangeable, and therefore actually commodification working as something as an antithetical movement to branding. So putting two very different logics of the commodity into play with one another. And I realized that there were a number of cultural and moral layers inflected onto generic drugs, and that my own actions as a clinician and scholar were already colored by this context. There were reasons why I had assumed that there was something virtuous about generic drugs and something not virtuous about brand name drugs, which had to do with a production of that dichotomy that had taken place in the late 20th century. And it was important to understand how and why. And so this led to the second book on generic, the unbranding of modern medicines. And just to relieve you of the responsibility of reading this book, I'll say this book did two things principally. It first worked to break down that dichotomy between generic and brand and show that the concept of an interchangeable equivalent drug has been highly mobile, has existed for a long time, but it has taken different moments and different regimes. And it's based on shifting sciences as well, and has itself helped to bring new sciences into being in the quest to either destabilize or shore up confidence in whether one drug was equivalent to another. And that this is based on scientific forms as well as political, legal, economic, and cultural dimensions of what can be constituted as the same or good enough in modern medicine. And I could give a whole talk on this, I won't, but one question would be to ask, well, what kind of proof is required to show that a generic drug is equivalent to the brand name drug? Well, again, I'll ask you as an audience, what kind of proofs do you think are required in the UK and the US and Canada to demonstrate that a drug is the same? What do you need to have? What do you need to know?
Composition.
So composition, and by which, and so expand on that for me for a moment.
The active pharmaceutical ingredients is equivalent, and the presentation is equivalent.
Yeah, so these are two very important functions, because one is to say the active pharmaceutical ingredient, and an easy way to criticize or to think about biomedicine as being as requiring the molecularization of medicine is to suggest that the therapeutic is just the molecule, just the active pharmaceutical ingredient. But by focusing on composition and focusing on presentation, you realize that there are all of these other things that are physically in there, in the pill, in the elixir, in the injectable, that also need to be regulated as well. And so these chemical standards of equivalence are sort of an initial basis. Is it the same chemical? And we can use concepts from chemistry to say, well, what's the degree of purity? Is the same amount present? And, can we demonstrate that it's consistent dose to dose? And there's physical dimensions as well. The illustration here is of an early standard proof of testing dissolution, which is to say, if you take a tablet of the brand version and a tablet of the generic version, and you plop them into water, do they dissolve at the same rate into water? But there are reasons why cases came up in which even these proofs, these chemical proofs, did not guarantee that the presentation, as you're saying, of the drug to the relevant site of action in the patient's body was actually the same. And so what do you do with a form of knowledge that suggests that physicochemical proofs are equivalent are insufficient? Well, there's two. It depends a lot on where you're sitting from. If you are if you're a brand name pharmaceutical factory, you mobilize this data as a proof of inequivalence and a reason why policies that suggest the interchangeability of generic drugs should be strongly opposed, either on a policy arena or approach clinicians or approach patients. If you are the FDA, you work on designing new standards. And so here was one test that was meant to get past this problem. This is one of my favorites. It's called the Erwica AT3. I found this in the FDA archives through a Freedom of Information request. And this is an attempt to reproduce the human stomach and small intestine in the regulatory laboratory. And if you can see here, there's the centerpiece of it is a carefully blown piece of glass which replicates either the gastric rugae, the folds inside the stomach, or the plica intestinalis, the sort of shaping of the small intestine. Up on the left is what was called a patented peristaltic pump, which would simulate the sort of squishy motions of your intestines. And you would place initially in there a vial of standardized USP gastric juice. First, put a pill inside of the tube, and then the gastric juice would squish around, the tube would bump around, and then you take it out, and then you replace the gastric juice with a vial of USP-approved peptic juice or small intestine juice. It's different pH, different sorts of enzymes in there, and it would squish around. And at the end, if the pill had dissolved, you could say it worked. And if the pill was still there in solid function, it hadn't. And of course, this then gives, this test is considered, but ultimately discarded after a series of I won't go into the details, but some highly public moments involving the inequivalence of an antibiotic and of some heart medicines as well. It suggests that actually what you really needed was proof that the drug dissolved into the bloodstream of the patient. And so here, humans are now being brought into the approval of generic drugs. Now, each of these steps involves a new scientific form of demonstrating pharmaceutical equivalence. It also increases a set of regulatory requirements for a would-be generic manufactured use, and therefore helps contribute to the cost of development and ultimately the price of the generic drug as well. So there's trade-offs every step of the way on who should demonstrate the burden of proof. Is it on the brand name industry to demonstrate proof of inequivalence, or on the would-be generic manufacturer to demonstrate proof of equivalence? And the book traces this, the politics and the science of this as co-produced, as intertwined. Here you can see an example of an early formulation of testing of two pharmaceutically supposedly equivalent versions of an anti-diabetic drug, which nonetheless perform very differently if one measures on the y-axis here the amount of the drug found in the bloodstream of test subjects a certain number of hours after dose. And these kinds of graphs, when the FDA began to use these kinds of graphs as proofs of equivalence, they didn't know how to calculate the area under these curves and to come up with a comparison. So what they did literally is they produced these graphs. They then printed them on special heavy pieces of cardboard, cut the area under the curve out, and weighed them on scales to see. And so ultimately, weighing pieces of cardboard made from graphs of these pharmaceutical trials were used as a regulatory measure of pharmaceutical equivalence. Since then, they've developed mathematical means as well. Now, the second thing the book did, and I had not expected this at the beginning of the project, was to question the political and cultural assumptions laid on the generic industry as a form of public good, and likewise question this naturalization of the pharmaceutical life cycle that generic policy had come to support. And I'll sketch this out here. And I want to really stress here that a lot of work went into this book into trying neither to demonize the brand name industry nor valorize the generic industry, but understand how one could look at the science and politics at stake from both of these positions. And this is a sort of chart. This is borrowed from the SEC filings of a company called Concordia. But this is a kind of chart that we see frequently about a natural life cycle of drugs, which invokes a kind of a narrative of the generic drug as a thing in the world. In the aftermath of the 1984 Hatch-Waxman Act, which extended patent life for brand name pharmaceuticals, I mentioned, also provided a clear pathway for generic drug approval. Generics became a de facto American policy for controlling drug prices. Since that time, we've come to naturalize this approach that balances innovation and access. And it goes something like this. In the first on-patent phase of a drug's life, the drug is new. It needs to be expensive to recoup the costs of innovation. These high prices are permitted and protected by federally sanctioned monopolies designed to help ensure incentive for innovation. Now, once the drug goes off patent, however, the assumption is the invisible hand of the market suggests many competitors come in, drives competition. This drives a dramatic drop in the drug's price and promotes access. And so somehow in this graph, in the natural life cycle of a drug, when a drug is young, it's expensive, it's not accessible, but it supports innovation. Once a drug is old, it's cheap. And I want to suggest, however, that this natural logic itself celebrates only one of many ways of approaching the problem of drug prices, and that this is fundamentally a free market approach. There is nothing in supporting generic competition that contests a free market approach to healthcare. In fact, it relies on a notion that the invisible hand is what will promote access. And so far, so good. And we can talk about how that's happened in the case of Diaro, right? It was a brand name drug. Now it is the cheap, effective option available for the multitudes and effective at reducing hypertension. And this approach has generated more than $1 trillion in savings over the past decade alone in the United States, according to the Generic Pharmaceutical Association, except, as we've learned in recent years, when it doesn't. And I want to spend the rest of the talk talking about this, that I became aware of this when investigating insulin compliance or adherence with my own patients in my clinic in Baltimore. And as many of you know, there are many reasons why it's hard for people living with diabetes to adhere to their medication regimens. And again, this question of adherence, of the success in managing insulin regimens for patients with diabetes, this is a crucial question for I think the WHO Collaborating Center to take up. It's one area to demonstrate the value of attention to cultural context in health and medicine. We can list some of them: health literacy, competing cultural understandings of disease and cure, the complex structures of work, family, and organization of daily life, mental illness, logistical difficulties, and other factors. Non-adherence is a wide open space for understanding the importance of the social and cultural context of health. But by the logic above, the cost of a drug first patented in 1923 should not be one of them. If we remember that life cycle I just showed you, insulin should be dirt cheap. So when I started talking to my patients about why they were having a hard time adhering to their insulin schedule, and they answered the cost of an insulin vial, I at first had a hard time believing them. It was only when I began hearing this increasingly. They skimped on their own meds, they hoarded insulin, they stretched one vial over multiple months, or simply went off the med altogether because they had to spend their money on things like food, their children. I started calling some pharmacies and realized that in Baltimore, if you had no health insurance, the cost of a vial of insulin was upwards of $200 a month at the pharmacy without insurance. And they're right. The price of Eli Lilly's Humalog had been going up dramatically. From $21 a vial in 1996 to more than $250 a vial by 2016. This is a more than 700% increase in price, even accounting for inflation. And I initially thought, well, this has to be the more expensive version of insulin, right? So what I need to do is pay more attention to this and make sure that my patients are getting the generic insulin. And I called several pharmacies. I called the FDA to learn that in the year 2015, when I was learning about this, there was no generic insulin available for sale in the United States. And as a historian, as an internist, this posed a fundamental problem. How could this be, right? I'm in the middle of writing a book on generic drugs and seem to violate all the basic narratives of the industry. Most of my colleagues in medicine had no awareness of this issue either. They, like me, assumed there was generic cheap insulin. And again, insulin, it was a wonder drug of the 1920s, right? But we're living near 2015. And the few scholars that had looked at the problem of insulin prices thought of it in exclusively 21st century terms. That's to say, as a new problem of copying the products of biotech, which presented different problems of proof of similarity than the older small molecule drugs. And Humulin was the first successful drug of the biotech era, a recombinant human insulin produced through modified bacteria. No wonder that it would be hard to copy and that a generic version might take longer to appeal. The solution should be a new regulatory pathway for biosimilarity in biotech drugs. But this ignores the entire history of insulin over the rest of the 20th century, before the biotech industry existed, right? What of all the insulins made before Humulin? Why were they no longer available? Why was there no generic version of 1925 insulin in 2015, or 1945 insulin, or 1965 insulin? Granted, if I had diabetes, I would rather take 2015 insulin in 2015, but I'd rather take 1965 or 1945 or 1925 insulin than no insulin. And the fact that it was simply whisked off the market posed a real challenge to this natural history of generic drugs. And a colleague of mine, also an internist interested in looking at the out-of-pocket realities patients face in the drugstore, worked with me to take a closer look in the story. We learned that insulin was not one drug, but many. There are a series of newer versions that steadily replaced the old ones in an iterative network of planned obsolescence. And on some level, this happens in almost all areas of drugs, like antibiotics, for example, in which lots of newer classes with broader and broader coverages came to displace penicillin. But unlike insulin, you can still get penicillin in the 21st century in the United States. In the US, you can no longer get the original pork or beef insulin. It just doesn't exist. And so here, again, I can graphically demonstrate this early wonder drug of the 1920s, originally discovered in 1921, patented in 1923, in parts that the patent holders could sell the patent for $1 to ensure access to affordable insulin at high quality for all Americans. Yet when the original patent ran out in the 1940s, new patents had emerged from manufacturers for longer lasting insulins, NPH versions, for example, which lasted longer in the body. By the 60s, when those patents are expiring, there are yet newer forms of insulin that begin new patent lives, which have different, more natural profiles, the lente and semi-lente insulins. Or you can see here the monocompetent insulins, which were less entogenic. Remember, these are all animal products, and so you can have an allergic reaction to some of them. And these monocompetent, newer insulins produced fewer allergic reactions. I want to point out all of these changes. I'm not suggesting these are Me Too drugs. These are real innovations. I think they make insulin a better product. But with each shift towards the new comes a forgetting of the old and a forgetting of some sort of commitment to accessibility once the older version is allowed to become generic. And so no generic market essentially emerges. And so at this point in time, you're left in 2015 with only these two forms of insulin on the market. There's the recombinant DNA, like Humulin, and then there's these newer analog DNA products where they take human DNA and tweak it to make it a little better and produce it through bacteria. And so this is more effective. This is safer than the insulin available in 1923. But for the person who cannot afford a nearly $400 vial of Lantus analog insulin in 2015, there are few cheaper options. And I want to just stress here the global dimensions of this as well. These older products have disappeared from the market, not only in the US, but around the world. In low-income countries, as well as high-income, these older, cheaper insulins have largely been squeezed out of the markets. You can see here in blue are the newer analog insulins, in red are the first biotech insulins, and in green is the availability of animal insulin products. And the WHO is now considering a motion to make insulin analogs, the blue ones, part of the essential medicines list, which on the surface sounds like a wonderful move. But for many advocates of patients living with diabetes in research-poor settings, now worry that this will simply bump human insulins as well as animal insulins out of production for the poorest nations, leaving millions of people with diabetes still unable to afford the insulin they need to live. And so this is a very real problem, and I would suggest that history has been part of the problem. If we go back to the marketing, for example, of Humulin, this first biotech insulin, here's an ad from the UK marketing of Humulin, and it says he's 4 years old and already he's living in the past. And the rest of the text of the ad goes on to emphasize the immorality of the prescribing physician who would continue to use an animal insulin now that human insulin is available. So that the displacement of these older forms has been part of a continued mobilization of historical narratives of the importance of innovation, again, without picking up that piece of maintenance and accessibility. Now, I want to conclude by coming to one final session about thinking about other drugs that have also older drugs that continue to violate this natural history in which the older a drug is, the cheaper it should be. The past 5 years have seen so many examples, certainly in the United States, but also elsewhere around the world, of older drugs that should be cheap that become newly expensive. The asthma inhaler, albuterol, which shifted from being a generic drug to being a brand name drug, it still is. The ancient anti-gout drug, colchicine, known for millennia, in which shifted to a branded monopoly within the United States in the past 10 years. All of these are deemed essential medicines by the WHO. All of them are newly accessible to many patients in the US and elsewhere because of anti-competitive tactics that allow manufacturers to raise prices on old drugs. And none of these cases, in the US at least, are more famous now than that of Daraprim, this old anti-parasitic agent, pyrimethamine, on the WHO list of essential medicines, which did not develop a competitive market in the US after its patent expired. And although the original manufacturer of Daraprim, Glaxo, still sells the drug for roughly 66 cents in the UK. And here's one of these cases, again, where the original branded manufacturer is not to be demonized, right? It is indeed the later would-be generic manufacturer, Turing Pharmaceuticals, a startup firm whose CEO, Martin Shkreli, briefly became the most hated man on the internet And it's hard to hold on to that title for long these days. After hiking the price of the drug from $13.50 a pill to $750 a pill overnight, this is a 5,000% markup overnight, simply as he defended himself in congressional hearings because he could. And the story of the Daraprim price hike followed by the EpiPen price hike, a similar dramatic increase in a drug whose manufacturer, Mylan, had done nothing to actually develop the drug, a drug that had been off patent for decades, whose price could be increased because even though it was off patent, there was no competitive market. And this effective monopoly allowed for a form of price gouging. Now, this made for good cable news, and appearing just as it did after the launch of my book on generic drugs, helped to drive book sales, as well as opportunities to engage with larger audiences. And I soon found myself writing pieces for popular magazines. This is a new genre for me. There's a piece in Forbes, a piece in The Atlantic, a piece in Slate, about how historical examination of the dynamic quality of the generic drug industry, the assumptions that we have made in believing this natural life cycle of drugs, left us vulnerable to these kinds of exploitive maneuvers because there was simply an assumption that no generic drug maker, no off-patent drug maker would act in this way. Also addressing panels that sprung up, such as the National Academy of Sciences, Engineering, and Medicine, briefing committees of the U.S. Senate. You'll have to look at a couple of pictures of me here, I apologize. And also testifying in the United States House of Representatives on the problem of anti-competitive strategies in the off-patent drug field. And this was a new form of engagement for me. It's several steps beyond simply writing a history that could be policy relevant. It was both exciting and uncomfortable. And like many of you, I used transcripts of policymaking bodies as primary source material as a historian. Being there in the room, I would argue, has now given me an additional ethnographic sensibility and insight into these spaces, but it also involved crossing a line and becoming an actor in the story I was narrating. And for many historians, part of the reason we're historians is that we're not in that story. And yet, trying to engage with that positionality, realizing that we have to put ourselves in the frame, it offers certain possibilities. And my goal in these settings was to hold true to our traditions of scholarship, to use history to defamiliarize the truisms that both the political right and the left brought with them into conversations about pharmaceutical policy, to demonstrate why it was important to come to terms with the failings of free market ideologies, and understand how this vulnerability had been built into the system we now inhabited because of a set of assumptions that we shared. And I found myself going to these briefings and these committee meetings on Capitol Hill, along with other social scientists and humanists, other epidemiologists, pharmacists, economists, and clinicians who are also trying to translate the value of their academic work into this policy arena. And even if the US Congress was unable to pass any legislation to prevent another Martin Shkreli from doing the same thing on another off-patent drug, our participation in these briefings was heard. And when the Senate Special Committee on Aging, which we had briefed extensively, produced a report drawing attention to this problem, we found that they listened to the scholarship that we had presented and actually suggested that somehow this engagement had participated in the policymaking process, not specifically as an advocate or an activist, but in a way in which we were directly informing the process itself. On the way back from one of these briefings, I had a conversation with a colleague in the Johns Hopkins School of Public Health who I hadn't really worked with before, Josh Sharfstein, who had been a deputy commissioner at the Food and Drug Administration. And Josh was interested in the history of the FDA. We discussed many kinds of actions the FDA could take, based in parts on actions the FDA had taken at different moments in the 20th century. And together with a third colleague, Jerry Anderson, a professor of health policy, wrote a piece in the Journal of the American Medical Association about options the FDA had, if it wanted to do things without congressional approval that might help to close the loopholes for off-patent drug price gouging. And to our pleasant surprise, they took our recommendations and they produced new regulations that address these loopholes on their own and worked to close some of these loopholes so that someone couldn't just sit on the fact that they were the only approved generic drug in their field and use that as a sturdy base from which to use the regulatory lag of the FDA as a bulwark to actually insulate their own prices. In a somewhat chaotic environment of Washington these days, also with Congress increasingly unable to, well, I wouldn't say increasingly, but certainly at the present time not yet able to act on issues of drug prices, state governments have also become an increasingly important political site for those interested in maintaining the affordable prescription drugs. And in my own state of Maryland, The Attorney General, Brian Frosch, had vocally called on Congress to close loopholes by which another Martin Shkreli could increase prices on off-patent medicines in the future. And after these calls produced no effect on a federal stage, the Attorney General turned his attention inward and focused on what he could do as Attorney General of the state of Maryland to protect consumers in this arena, and ultimately decided that he could do nothing under existing laws. And using the power of his position, proposed a new law in the state of Maryland. And I was asked to consult with his legal team as they framed the bill, which essentially gave the Attorney General the power to demand justification for egregious price increases in an off-patent drug in a non-competitive market, and allowed the AG to press charges in court on what would be called an unconscionably high price increase of an off-patent drug. And the rationale was that this case was clear, that unlike on-patent or branded drugs, these are drugs in which all the costs of innovation had already been borne out a long time ago. And so any price increase that is not related to, say, a price in the raw materials or shipping costs could be actionable as a form of price gouge. At any rate, I began realizing at this point that my own role had changed from a historian that could be tolerated to a historian that had something useful to say, to a historian now part of an interdisciplinary policy team, and now in this iteration locally in Maryland, to a historian that was helping to write and pass a new law. And so that last category brought with it very different roles than any of the ones before. And the rabbit hole is deep and involved many twists and transformations. The state capital of Maryland, Annapolis, is significantly smaller than Washington. It seems that everybody knows who's having dinner with whom, and these dinners are happening continuously. There are long hallways that seem to occupy much, much more surface area than the actual volume of the hearing rooms themselves. And in those hallways, many, many lobbyists are continuously meeting. And as the House, I testified at a hearing. I thought I was done. I had done my part as an engaged scholar, but that was just the beginning. And as the House committee got down to business, they held a series of work groups on this bill. And for each of these meetings, the brand name industry and the generic industry would produce, their lobbyists would produce their own amendments to the bill, which effectively, each of these effectively gutted the ability of the Attorney General to act. And most of these concerned the strict definition of price gouging to involve only absurdly high price increases, so that you would set a high threshold that something could only be called price gouging if it was more than 1,000% increase on drug, or more than 100% in 1 year, or more than 50% in 1 year. And in each of these meetings, I was asked to come along as the Attorney General's expert witness. And I just want to set the stage for you a little bit, because it's a hearing room. It's a U-shaped table, Democratic and Republican, delegates of the House of Representatives. And then there's a bench, and there's the Attorney General and a consumer organizer and me on one side of it. And the other side of it is essentially the pharma lobbyist and a seat that's just open. And then behind us are 2 rows of people that are her experts. And so depending on the practice, the question, it was a question of pharmacoeconomics, you'd pull her a pharmacoeconomist. At one point I mentioned insulin pricing, and so she reached back and pulled a vice president of Eli Lilly to talk about why insulin was the best bargain available in the pharmaceutical markets today. And yet I was there not just as the historian expert, but somehow I had become an economist in the process. I had become a political strategist. And I also am now written into the story. So there are these transcripts in which I'm almost comically being referred to as, if perhaps somewhat sarcastically, as the good Dr. Greene or the good professor. And I could never tell exactly in what sense that phrase was meant by lawmakers and lobbyists alike. But all the same, the bill did well. After the House committee voted the bill to the House of Delegates, it passed with an overwhelming margin, something like 137 to 4. In the Senate, it got into the weeds, and what happened in the Senate was a desire to put guardrails on the bill, to come back to this issue. Should there be a numerical threshold for deciding when price gouging was taking place? And in a series of conversations, I had to invoke the problem of setting up any percentage, right? So let's say you say 50% increase. You have to be more than, the drug has to increase more than 50% in price to be a form of price gouging. Well, if you look at the price increases on EpiPen, by which it moved from being $124 for a 2-vial package to more than $600 over a 7-year period, but the price increase is pretty much 28% per year, almost exactly 28%, almost as if someone had planned to do this iteratively and demonstrate what happens when you compound price increases over time. It also has the problem of actually perhaps creating a perverse incentive. If you say, well, in the pharmaceutical industry, we know prices keep on going up all the time, and so we say 50% is a good threshold, it actually produces a shelter that for a company to increase its prices by 49% every year can say, well, clearly we're not price gouging. So it actually could produce a perverse incentive to move everything rightwards. And so I found myself, being brought into this process specifically to make arguments that should be obvious to anybody who's taken an undergraduate economics class, which I have to admit I never took. Mm-hmm. I can't present myself as having expertise in economics using any measure. But this form of expertise that I was performing, what was ultimately part of an influential process in helping this bill pass the House and then the Senate. Passed the Senate 47-4. Most Republicans also voting for the measure, as well as Democrats. And then it finally passed the Assembly 137-2, an overwhelming majority. And just this weekend, just shortly before I got onto the plane, the governor of Maryland, Larry Hogan, allowed the bill to become law. So as of this week, there is a new law in Maryland that makes the price gouging of off-patent medicines illegal. And the role that I've played in this is a very different kind of role than I ever would have expected to take on as a historian of medicine, even as a historian of medicine interested in producing policy. Now, I want to say, though, I offer the story not as triumph or tragedy, but as an exploration of the kinds of engagement which historians and scholars of medical humanities can have in different arenas in policy and practice. And in my own thinking, this constitutes a form of translational history of medicine, increasingly important to both historians, other social scientists, humanists, and policymakers and practitioners. How can we as scholars make the findings of our research relevant to the pragmatic concerns of these fields without reducing or flattening the value of our work into a simple utilitarian or adversal function in the process? And I want to point out that when writing this book on generic drug, the lobbying organization of the generic drug industry was not my ally, but they were not my adversary. When showing up in these hearings, they became my adversary. And it surprised me on the one hand, because I continuously made the argument that to the extent that the generic drug industry does promote competitive reductions in prices, they are incredibly value in health policy. We're only talking about a fringe group. This legislation only addresses a small group of actors that have been exploiting these loopholes. You would think, or I would have thought, that the generic industry would have supported such a measure. But like most industries, though, of course, they do not want to support any regulation of their own industry that they can't immediately see benefit through. And so, of course, we were in an adversarial relationship. Were I simply an expert consultant, that wouldn't be adversarial, but as an advocate, it became adversarial. Now, I'm far from the first to ask these questions. This year, the American Association of the History of Medicine recognized Daniel M. Fox, the President Emeritus of the Milbank Foundation, with a Lifetime Achievement Award for a long career at the borderlands of history of medicine and practical engagements with health policy. The work of Rosemary Stevens, for example, has addressed this intersection, as has the work of my own dissertation advisor, Alan Brandt, who wrote eloquently of the challenges of serving as a historical expert witness in the U.S. Department of Justice's case against the tobacco industry. Now, Brandt considered 3 levels of engagement: writing policy-relevant history, serving as a historian on a policy committee, and then jumping into the field as an advocate. And in a way, although his examples focus on the courtroom and mine focus more on the legislative arena, these 3 steps that I've charted out for you suggest a similar progression of how deep you sink into the rabbit hole of engagement with policy. Now, beyond this, though, my own story illustrates the benefits and risks of seeking out engagement in practice and policy. And so on the plus part, writing in clinical journals and popular magazines can make the value of historical perspective visible to audiences that would have never read my book, and certainly would never have read my scholarly articles in the Bulletin of the History of Medicine or the Journal of the History of Medicine and Allied Sciences. Even though these are wonderful journals, they just wouldn't have read them. I want to point out that it's difficult to write in units of 2,500 words or 1,200 words, as the perspective section of the New England Journal of Medicine requires. It can be hard to figure out how to work in these space constraints without footnotes and without jargon, but every piece put out in the Lancet of the New England Journal of Medicine extends the possibility of this traction, this space of engagement, of conversation with audiences that might actually find the kind of work we do to be meaningful and relevant, and then might go actually read our scholarly articles and our books. And I've consistently maintained that writing for these popular clinical and policy audiences doesn't need to require dumbing down. It requires a willingness to work in a new genre, to accept a different set of formalist constraints. And if you see that as a challenge, as a new genre, it can actually be a kind of a game in its own way. And one great advantage we have in this process is that policy, like historical scholarship, has its narratives. A well-told story at the right time and right place can sway a crucial vote or support a key program. Now, publishing for broader audiences is one thing, though, and serving as an expert in government panels another. I offer my own story as a cautionary tale here. And this past year was my sabbatical, and I effectively squandered it, trying to communicate the value of my last book to audiences in the policy arena rather than writing my next book. And incidentally, I would have loved to give you a talk about the next book, and maybe in a future visit when I've spent my time doing that, I will do that. But in the process of engaging as an expert, I became less visible as a historian and more generalized as a generic expert. And I expected to counter any of a number of more specialized experts on the better funded pharma bench. And along the way, my own contributions, I want to point out critically here, were often reduced to graphs, mobilizing something like that EpiPen graph at a key moment in deliberation of a House committee is no different from the form of thinly mobilized historical critique that I criticized in the beginning of my talk, right? And so as part of the passage through this process, I became the thing that I was critical of. And I want to attend on it, as my own contributions became reduced to graphs and back-of-the-envelope calculations and simple counters to a repeated series of moves by the pharmaceutical industry. I became part of that problem as well. I'd like to approach this as a discussion. Now that the bill has become law, the law will still face its own legal challenges. Its implementation is far from certain. Even if it's fully enacted, I should also point out that the solution the bill offers is a tiny, tiny part of the problem of drug prices in the 21st century. It's just a very small step towards addressing the conceptual blind spot we have towards ensuring access to affordable medicines, to affordable 20th century cures in the 21st century, let alone even beginning to approach the problem of how to make 21st century cures more affordable, or at least less outrageously expensive. So to bring this talk to an end then, it's been immensely gratifying and quite humbling to find that my own modest work as a scholar, as a historian, can make concrete contributions towards ensuring more equitable access towards essential medicines in the 21st century, even if that measure is just a small one. As Dora and I noted in our research on the hidden costs of diphtheria prevention, the world forgets about its old cures in a continuous embrace of the new. We focus on innovation and not on maintenance. In the early 21st century, so many vital pieces of the infrastructure of care built by 20th century biomedicine and public health are being left to crumble or actively being dismantled. And as historians, we can and should have something to say about that. I'm delighted that the University of Exeter is making it a priority for humanists and social scientists of health and medicine to engage in these problems, and that you are working with the World Health Organization, the Wellcome Trust, and others to insist that the social and cultural context of care matter more than any single new innovation in turning the promises of modern medicine into reality. Thank you so much for your attention today.
Sharon, thank you very much for a richly rewarding, provocative, challenging, expansive talk. And I really like that suggestion at the end that you have moved from brand to generic. I thought that was really neatly done. Thank you very much for that. We're open to questions. We have plenty of time for anybody here or online to ask questions. Yeah.
Thank you so much. That's absolutely fascinating. Particularly the last section made me think about how you perform disciplinary expertise. And you've been speaking mainly from the position of a historian.
Yes.
But I also noticed on one of the slides with the memorandum, you were Jeremy Greene, MD. And
Yes.
he was kind of left out.
Yes, yes.
So my question is, does it make a difference that you also appear, that you are perceived as a medical authority, and does that give you an authority that you need to have an impact on these debates?
So that's a great question, yeah. Thank you. I'm glad you picked up on that. I left that there. Now, I produced this memo essentially, I think around 11 o'clock at night in response to a move that had been made during a dinner between lobbyists and key members of the Senate Finance Committee that we learned about from another contact in Annapolis, was funneled to me then through the Attorney General's office. So, and I wanted to quickly because the bill was the threat was it was going to go into committee the next day. And I wanted to make sure that there was a voice suggesting the problem of why just simply saying, well, 30% increase would be okay. It is not actually going to produce a viable solution. Would not prevent a future EpiPen problem. So I wrote that. I sent it to the Attorney General's office. They then formatted it as a memorandum, because what do I know about how to produce memoranda to the chair of the Senate Finance Committee? And they represented me as Jeremy Greene, MD. Now, I didn't correct them and put the PhD back in. And yet you're right in saying that was there. And so sometimes in committee being referred to as the good doctor, it has consistently been a viable path towards policy making to have clinical experience be presented in these policymaking sessions. And so I think the fact that I could talk from my clinical experience of patients who I worked with that had a hard time affording off-patent drugs and say this is actually a problem in community health centers in Baltimore right now was very important to this legislation. But I wouldn't generalize it from it too far, right? I think that it's very easy for many of us in a place like this to grant too much authority to the MD in these spheres of policy. And I could point to a number of social scientists and historians and humanists of medicine that don't have MDs that have been very effective in mobilizing the policy arena. I mean, just off the top of my head, I mean, I've already mentioned Alan Brandt a few times, and one of the things that one of the fascinating things about having Alan as a mentor, as I developed as a scholar, is recognizing that everyone within the medical school, at Harvard Medical School, treated him as if he was a peer who understood the medical education process and problems of existing and the broader sociology of the medical arena, and indeed had relevant expertise there. Many people just assumed he was a clinician, but this came out of a career of engaging himself in these spaces. I could also point towards another colleague who I value quite a bit as a mentor as well, as Keith Whaley, whose work has dramatically opened up possibilities for arguing for the relevance of history and health policy, certainly in the United States. And yet is not a clinician, but is unapologetic. And so I mention this because I think there's a problem that can happen among medical humanists, medical social scientists that don't have the MD to suggest, well, especially if I give a talk, to say, well, that's all well and good for you. You have the MD, people will listen to you. Think about what it's like for us. But I think to do so, it's not to say I don't have sympathy, but I think that there's a risk of recapitulating that power structure by assuming that the lack of MD means one is less credible. And I think it almost helps to project the irrelevance of that you do have expertise in your realm, and that expertise is valuable. And that all the steps that I need to take to demonstrate to people why history is valuable, these are the same steps that you need to take as well. But yeah, that's a great question.
I was thinking the same kind of thing, but there's another dimension to that. And I was thinking about people like Virginia Barrage writing in this country on alcohol policy or smoking policy. And one of the key features of the centre is to co-locate and enable conversations.
Yes.
Virginia is in the London School of Hygiene, so she's working with health policy within the Health Policy Research Unit. The other aspect of your story, though, is that your clinical experience provides you with another location to identify the problems. The story you started with about insulin, for example,
yes,
is very much driven by the ability to see a practical health-related issue in the community. Now, one of the things we have been thinking about is how we bring it together. You have the benefit of two identities in some ways coming together perhaps through this process. But the challenge for us is how do we bring the humanities and social science scholars into the same space as the clinicians, the policymakers, to enable us to see those problems in new ways, in the way that you've had that experience.
Yeah, and I think that's, and I want to highlight the importance of that process, is that for me the solution is not producing legions of MD PhDs, right? Although I'm happy to support MD PhD training in humanities and social sciences, and there's a wonderful cadre of dual degree trainees that have been, I've had the privilege of working with over the past few years. But it is creating these settings where the clinic becomes an ethnographic site for the historian as well as the anthropologist or sociologist. And for me, it's essential. It's part of how my career works is by trying, or to the extent that it has worked. I don't want to suggest it will continue. I hope it will continue to work. But part of why it has worked is by having an ability of insisting on a two-way street in my own life that the work that I do as a clinician informs the questions I ask. And I think it's certainly true of both prescribing by numbers and generic, but also that the work I do as a historian, as a social science and medical humanist, informs the nature of medical practice. Now, sometimes that's destabilizing, right? So in a code situation, right, when I was a senior in my residency running the code team, it didn't help that I could produce a discursive critique of CPR or contest the epistemological basis of how we think CPR. Where like I needed to memorize that process, and yet that's not the situation that I place myself in now as a clinician. And so when counseling patients who show clinical signs of depression or anxiety, for example, Felicity and I were speaking about this just before the session. I find that historicizing the diagnosis is actually really quite helpful because it forms a way of talking about the problems, that this is the way that our societal response to depression is geared more towards things like antidepressants than, say, psychodynamic psychotherapy, or more broadly recognizing the broader social and specifically structural forms that actually provide many of the stresses that lead to that depression and anxiety. So that there are spaces in which, if you choose the right spaces, that actual historical means. Now, I'm saying this within my existence as a single person who tries to maintain some unity of or coherence as a person. But the question that you're asking, Mark, is how do you do that as a faculty, right? Or how do you do this as a collaborative structure? And I think one of the questions here is what are the lateral approaches that allow a question that is of equal importance to a clinician or a policymaker and a historian or a philosopher or a scholar of literature to actually exist in a space on equal footing. But what I mean to stress in my own narrative is that I don't want this to be a one-way street, right? I really want to have a binocular vision. And I think the same is true for a center like this. And so I think that one of the questions is how do we move beyond the narratives that we're very good at producing as social scientists about, oh, the problems of biomedicine, and they are reductionist, or they do all of these things that atomize the patient, or they are not concerned about the subjective quality of the patient, and recognize the spaces in which a clinician or a policymaker might really be yearning to do more of this, but not recognize they don't have the skills. So it's those kinds of places. Yeah.
Well, sorry, I'm going to ask the same question
again,
because I think I get a sense we all had the same experience. And what I suppose the challenge I would bring to you, and to try and be a little bit more critical of some of the things you said, which is only on the basis of, because I find it so exciting, is that the one group who kind of were silenced in your presentation of your patients or your publics, and yet it was your public who presented you with a problem which otherwise wouldn't have been encountered by you. Because it wasn't actually a medical problem as such. It was a problem of the lived reality of poverty, in fact, which had been exacerbated by political, economic pressures. So I think what I'm interested in, and I guess one of the things I'd love to be able to do with the centre, and as we progress this, is actually to see what means can we create which would allow for multiple publics to shape the kinds of problems which our own disciplinary expertises would tend to silence or not allow us to witness. So I think really that would be the challenge that I would come back to you.
Yeah.
What would be the way we would go forward on the basis of your work to allow that voice or those voices to really drive the opening of these multiple problems that you described?
Yeah, no, that's a great point, Robin, and I'll take that criticism very, very easily. I mean, I did not give you patient narratives, patient voices in this talk, and you're right to point that out. And in fact, it's been an interesting and challenging part of my engagement with journalists over the past year. I found several journalists who I've managed to, I could convince them of the problem, but then what they need to sell a story to their editors is the patient who can't afford it. And they would like to go through me to get a patient. And unfortunately, I can't produce patients who are willing to talk about their own inability to afford their medicines on a regular basis. It's so hard as a clinician to even get to the point where a patient is willing to tell me that they can't afford. It's very difficult, I think, to talk about these things. And oftentimes, I think there's many, many more cases in which I simply don't see it because people won't mention it unless I bring it up. So there's also an ambivalence I have about using, I haven't figured out yet how to use patient voices that I work with as a way of supporting my own scholarship. They inform my questions. And this is a problem that I think anthropologists deal with differently from historians, or different historians deal with differently. There's a patient who I remember very vividly when I was trying to figure out the questions behind what became the first book, Prescribing by Numbers. I was following as a medical student in continuity clinic. He had difficult to treat high blood pressure. We tried one medicine, it didn't work. We tried another one, it worked, but it produced terrible side effects. And we finally realized there was only one cocktail we could manage his blood pressure numbers on, and that made him impotent. And so I sat down and had this conversation saying, you know, this risk reduction we're doing, I can't guarantee this will ever materially prevent any symptom in your life, but I know that we're giving you this symptom of impotence. And then he responded to me and said, you know, listen, I'm 54. My father died of a heart attack when he was 55. I want to do everything I can to reduce my risk of a heart attack. I don't care if it makes me impotent. That's what we need to do. But as long as we're talking about this, could you also prescribe Viagra? And I could, you know, that kind of exposure, like I had not witnessed that before, and this has helped me understand a critique of the problem of medicalization in the 21st century as being not something that's imposed by the medical profession, or even just imposed by the pharmaceutical industry, but something we're all suspended within. And yet, he did not want me to quote him. So I can offer this as a paraphrased form, right, in this arena, but it wasn't part of the book. Which is to say, the voices of patients are crucial, and we need to figure out ways to incorporate them. And I am yet in these parts of my career, of my life, have not successfully figured out how to mobilize them individually yet. But as for the center, how do you begin to bring in patient populations, different forms of activists, of would-be patients, or you know, people existing in different spaces of the arena of negotiating disability, as well as engaging with questions of other forms of alterity, so that these different positions of, say, disability, of deafness, for example, which exists in a very different space than either disability or medicalization, but an uneasy relations to both of them. How do you begin to find these different stakeholders and bring them in? The other thing I would say, though, I realize I'm giving you a long answer, as much you can, I'm sorry, but is that part of the virtue of working in an interdisciplinary group. So as a historian, I find I continuously benefit from learning from what my colleagues in anthropology are doing and their ability to produce the means of attending to populations that are otherwise not visible. And it's easy for me to just then, well, these are not in the archive. But the challenge then for me in working with anthropologists is to say, well, when voices are not recorded in the archives I have, where else should I look? What's my responsibility? What can oral history do to stretch things out? So I do think that on a conceptual level, that's part of the virtue of a collaboration like this ability to then actually learn what you're not attending to by being pointed to by different fields. I also want to suggest, if any of you guys want to just jump in and answer Robin back directly, like, you don't all have to go through me, but I'm very interested in your other
We've
thoughts.
been trying to answer Robin back for a long time, and it just doesn't work. I think you do it very well there, actually. In fact, you've written several taglines for our centre there.
Yes.
What we're trying to do, so thank you.
Part of the work.
Question? Yeah.
I just wanted to dig a little deeper on the side of the media here after that question, especially. I'm a journalist and a clinician, so I have the benefit of kind of having perspectives of both. And I write on health, so I think I have a unique perspective. But like you said, a lot of journalists don't. And I guess I'm wondering if you, from your perspective, do you have any kind of tips for journalists of how we do go about breaking down these narratives that keep supporting this marginalization of voices and this misrepresentation of drugs in the media?
Yeah, that's a great question. Thank you for that. And I'll stress for the virtual audiences that the question has to do with what the field of journalism might be able to do to avoid simply recapitulating these sorts of, these power structured narratives. And I have to say that to the extent that I've learned to think about this, it's come largely through conversations with journalists, because I think that there has always been a set of constraints that journalists work within and yet bridle against. And I think one of the distinctions within journalism, not only health journalism, really all journalism, is this distinction between short-form journalism and long-form journalism. And then in short-form journalism, you only have so much space, so you really have to rely on a narrative that pre-exists that your audience will know. And long-form journalism, you can challenge those narratives a bit more. And of course, in the era of BuzzFeed, right, we are now in this ultra-short-form journalism, which is now, pressing everything even further away. And so I've learned from journalists about the genre narratives that they are forced to use when they work with editors. And so I think one of the questions is how to actually wield those narratives subversively, right? So that, what can you do to both give the hook that your editor needs, right, in order to sell that pitch of an article, and yet retain within them that they're a critical sensibility. Well, it's like this narrative, but we're going to turn on its head here, and you're not going to expect this. And this is how we'll open up a new problem. And I've really, really enjoyed this year working with a series of journalists I've been very impressed by. There's a journalist for the Washington Post who I've done a number of interviews with, but I've also learned so much from watching her, looking at her articles, seeing how she's able to open up problems in drug pricing and show why the public should attend to actors that might seem boring, but are actually really crucial to understanding the problematic spaces in which drug value is uncoupled from its worth. I also think that there have been a number of very successful programs to embed journalists within humanities programs. It's something the center might consider. The Knight Foundation funded something like this at MIT that actually took long-form journalists who had established themselves but would like to move further in their career and become more conversant in doing critical reporting on health in particular, and embedded them within actually an STS program. And so when I was at Harvard, I enjoyed working with some of these scholars. And at Hopkins, I still get to work with some of these people in DC as well. But again, I want to suggest it really is a two-way street. I actually think that as a body of scholars, there is a lot that we have to learn from journalists as to how to successfully communicate the work we do to broader audiences. So I would not pitch it as simply, how could we help journalists make it better, but what can be built with that interface? It's a great question, though. Do you have any thoughts on it yourself?
I think what you said is really interesting. For me, so much of it comes back to reinstating and re-encouraging the idea of the polymath. I'm very much similar to you in that I have multiple interests, and I feel like we are forced into one field or another. So to be able to come together even in a lecture like this across multiple disciplines and just be able to have conversations, I think, as a journalist is a hugely helpful thing to be able to do.
Yeah, no, I think very much so. And again, just to emphasize the sort of two-way street basis of it, that as both Robin and Mark were suggesting, that I have this privilege, you have this privilege of having this clinical space in which you'll attend to something, right? And then use a set of skills to defamiliarize it, right? Ask why is it that way? And that for social scientists who don't have the clinic at hand, there's always a challenge of how to find that space of attention. And I'd say there's a different party that might not be in this room right now, right? Which would invoke clinicians that are banging their heads against the wall, trying to deal with certain social problems that are so patently visible to them, but they can't fix. And somehow opening up that process of conversation, you can look at it in a couple different ways. These clinicians can be your informants in a social science study that you do where you're the investigator and they're the subjects, right? Or they can become co-philosophers. And it may be that it starts as one and then moves to the other. But so in a way of moving, beyond the polymath, of trying to create these places that Mark's referring to, where this other party of clinicians or of policymakers who are banging their heads against the wall, right? And actually giving them a place to not just be a source, but to also be an investigator, I think is an exciting possibility.
Thank you. I mean, the point you made about sort of secondments, if you like, for journalists and external partners is absolutely what we are working through, how we embed that in the central ethos as well. So it's a very well-made point. Other questions, Dan?
Thank you, Jeremy. Kind of made me homesick from Maryland.
It's a good crab season this year.
Perhaps of all the social, scientific, or humanities endeavors that have the most successful engagement with policy has been bioethics.
Yeah.
I don't But the sort of result of that has been that it gets accused of handmaiden, kind of thing, or even just favoring and letting medical terms just go by. How can historians and other...
It's very different metaphors.
How can that be avoided when historians go forward?
Yeah, that's a great question. I'm going to repeat the question. The question has to do with bioethics being, in many ways, a success story, certainly the past 30 years of creating traction of policy relevance and vitality and engaging humanities and medical and policy arenas, and yet these accusations are made in different ways, that the bioethicist can either be a gun for hire, can be a field in which some philosophers, many philosophy departments in the United States have distanced themselves from bioethics department along a kind of a familiar basic applied distinction, in which basic is to be elevated and applied is to be viewed with suspicion. The question is, how does history or other medical humanities avoid that? And I think it's a really interesting question. I did a collaborative project with Scott Podolsky, another medical historian and physician at Harvard, about the title was "Is the Medical Humanities for Sale?" And it was a historical piece about a debate between two actors in the 50s. William Greene. Well, I won't go into the details. You've already listened to me tell you enough histories today. But at the essence of it, there was this one figure, Felix Martí Ibáñez, who's a prolific medical historian, but who took a tremendous amount of funding from pharmaceutical firms and also became very interested in medical advertising and built a magazine that was designed to use medical history to expose physicians to pharmaceutical advertisements. And he pitched this idea very openly as here's the best possible use of the medical humanities is as a way to sell new drugs. And meanwhile, William Greene, sort of a very much an Oslerian humanist at the University of Iowa, editor of Annals of Internal Medicine, I think at the time, I may have this wrong, took a very significantly opposing view that, that actually it was very important for the humanities to produce a critical sensibility so that physicians were able to perceive the problems of pharmaceutical marketing, right? So, but you can see how the two of them are already illustrating the problems of engaged medical humanities in the 1950s, right? Now that excursus is a way of saying that I don't have the answer. That I think that relying on a notion of objectivity as a buffer is I think not going to work. That I think that whether it's a straw man or not, the sense that historians should be cautious of engaging in policy because it will damage their objectivity is the wrong argument. I do think it's important to be very conscious of position, or to use that anthropological term of positionality. And I think I would hope perhaps that bringing myself into the frame might make me a more responsible academic rather than a less responsible one, and that actually the fetish that historians still use of suggesting that we can write in a third person without putting ourselves in, as anthropologists have stopped being able to do that decades ago, it may well be that engaging these possible sources of bias may be the best way out. And I think that would hold true for bioethicists as well. I think one of the problems in the field of bioethics is that those bioethicists that have been accused of being handmaidens try to present the philosophical basis of bioethics as somehow itself insulating this inquiry from the base needs of the terrestrial Earth. And I think that's what has gotten the field of bioethics into trouble. I think were bioethicists more straightforward about their specific funding ties and relations, it'd be easier to position their arguments in that sense. So this is one of the reasons why I have not yet accepted funding from a pharmaceutical firm for any of the work that I've done. And it's not because I think specifically that pharmaceutical funding is itself a categorical evil, right? It's just that I recognize that were I to accept funding from a pharmaceutical firm, I would feel a responsibility to display that. And if I displayed it, it would color the way people were able to actually perceive the work that I did. Yeah, that's a short answer. I'd be interested in other thoughts that you might have as a collective in this problem. How do you engage without being seen as a sellsword? I've been watching Game of Thrones lately.
Any answers to that question would be appreciated. Or any other questions? Yeah. Ali.
You mentioned that as you moved from being a tolerated historian to one that actually jumped down the rabbit hole, you became less visible as a scholar. Have you any ideas on how you're going to manage that? Because it's a really real problem happening at the moment.
Sure. So, so the question is how to manage the problem of being less visible as a scholar as one becomes more visible as a policy expert or advocate. And I'd like to hear more about your own experience there. I mean, I would say myself, this is something that happened to me within the domains of the Maryland legislature, right? Or the halls of Congress, that I recognized that every time I went into these spaces, I would say, as a historian, this is the kind of information that I could present. This is what we do as historians. I hope it's useful to you. Or this is why I think it should be useful to you. But I felt that within those halls, I was increasingly treated as an expert, right, more generically. But I don't think that's affected yet my general ability to be a historian in other places. I meant to suggest that in that space, when you engage, it's even as much as you insist on being a historian, people treat you as a policy expert. But it's still very important for me to have spaces where I'm perceived as a historian. And I guess I'm interested in hearing your own experience, how you've seen that trade-off take shape.
It's quite easy to get confused.
Yeah.
Taking up your entire time.
Yes.
And I think also it depends on the kind of culture of the policy environment you're engaging with.
Yeah.
And the kind of problem that you're trying to deal with. I think I deal with men's mental health and suicide.
Yeah.
And a lot of the recommendations I make actually involve much wider societal changes, which are quite uncomfortable and difficult to deal with. So therefore, there's I think quite a war up against my ideas sometimes. So, you know, you can spend a lot of time making very sensible arguments because of political expediency doesn't really necessarily get you anywhere. So you have to watch also that you don't then lose yourself as a scholar and maintain that solid credibility further on.
Yeah, and I think you're right to flesh this problem out, right? Because this is something I didn't address in a talk or even in my initial answer here, but the time is a substantial problem, right? So that I've already sketched out for you the book Not Written, and I'm sure you have your books not written as well, and I still have some time to write that, but there is something very difficult about the urgency of such work as well, so that to the extent that one is successful in translating, it takes a lot of work, as you're suggesting, to even make these critiques visible or relevant, and then once that happens, then there is some self-propelling process whereby if something comes up, you're expected to comment on it. And there's a continual urgency in that it becomes hard to justify your time in the archive, your time at the writing table, unless you just start waking up earlier, which is a viable option. And so the time is a problem. I think the question of credibility as a scholar, I would hope it doesn't need to suffer from this process. But you're right, there is a threat, right? And there is a threat that if you are perceived merely as an advocate, you could be seen as losing credibility and actually negotiating the dangers of this process. And one thing I'd say here is that the bill that became a law just this week, I hope that it works. But partly as a historian, a concern that I have is, well, what could the unanticipated consequences of this bill be? And the generic pharmaceutical industry, which now renamed itself actually in the context of these hearings, it is now called the Association for Affordable Medicines, which is a richly ironic self-naming to solve the problem at hand for which it's being investigated. But at any rate, the AAM has come out against this bill, urged the governor to veto it, suggested that it was unconstitutional, that it was too vague, that it would have a chilling effect on the generic industry, that it would drive away competition and raise prices. Now, these are very self-interested arguments. I don't believe them. I think that the bill has been crafted specifically to have no effect in the competitive space and only address these rare occasions where there's a clear malfeasance of someone taking advantage of effectively a monopoly. But what if they're right? Right? If they're right, my ability to actually criticize this is I've already come out on this. It's hard for me to step back into this place publicly and say, well, let's look at these different stakeholders and see their different arguments, because I'm already in that space. So I think we do actually lose that when we engage. It's a space that's lost. Dora.
Yeah. Touch on that generic expertise that you mentioned, and I was particularly struck by the team of experts on one hand, and they're like the knight in shining balloon on the other. Like,
not too shiny.
But also, in my mind, it raises the question of kind of expectations that you put out there from others. You said that you're insisting that you're a historian, but people tend to forget that. And I see that in interactions with very limited involvement and engagement with patients and disability activists who, I come as a historian, and then immediately I get caught up in all kinds of answers and expectations from me that I cannot possibly fulfill. And when you say that, well, you're suddenly an economist and you're suddenly at this and that, the risk I see that you enter a realm as a historian, and then suddenly you're called upon or you're expected to, and it's very, I'm sure it's also very tempting to be able to, well, I'm the expert, I'm just going to, fight for the cause, but then it gets pretty shaky in terms of academic credibility as well as, as a historian, how are you going to, in what way engage with all these other broad questions.
Yeah, so I agree. It's uncomfortable. It's uncomfortable, and I'd like to retreat back and be able to say, well, I'm the historian in this endeavor. If this is an economic question, let's talk to an economist. Or this is a legal question, let's talk to a lawyer who can engage with, who's a legal scholar who's engaged with these problems. And I think that's one of the other virtues of a center like this, is that you can build up that expertise, that collective conversation, so that when you are actually called on to act rapidly, you can say, well, I'm a historian, but if you want to talk to a legal scholar, here's this person. And so this is actually what I tried. Yes, I tried to do that in that situation, and it helped. I put the Attorney General's office in touch with my colleague, my old colleague from Harvard, Aaron Kesselheim, who's a physician, intellectual property lawyer, who's written quite a bit about the IP dimensions of this. But there were moments in talking about the law in which I had to repeatedly say, I'm not an economist, but this is what I hear when I talk to my friends who are economists. Or I'm not a lawyer, but when I talk to a colleague who's a lawyer, this is what they said. Now, at Hopkins, we put together an interdisciplinary team to work on questions of drug pricing. And this is headed by Jerry Grootman, one of the authors of the JAMA article on the FDA that I showed you earlier. Also includes Joshua Sharfstein, who I had mentioned. It was another co-author on that. And other colleagues who are pharmacoepidemiologists like Caleb Alexander and Jody Heyman, legal scholars. So economist Antonio Trujillo. And so we meet every Tuesday. I was supposed to be there yesterday to discuss what's happened in the last week, what we can do. And they are a network that I can call upon. And I did. Before my hearings, I called upon many of them for these specific reasons. But they weren't all there in the room with me. And so it is an interesting point that in terms of scholarship, I think we can do that. And that helps become a justification for these kinds of collaborative venues, right? But then when you are being that expert, the world that views you as an expert won't respect that. Like they want you to be the expert, and it's very uncomfortable. And I try to always say at least once, forcefully, in any of these engagements, well, I'm a historian, and this is what historians do. This is the way we think about it. And if I were a lawyer, I might bring up these questions, but I'm not a lawyer. But that's not how the world wants you to perform as an expert.
Just very, very quickly, this thing you discussed, the kind of dialectic of objectivity and responsibility, I think is so important. Philippe Van Parijs, I don't know if you know his work on universal basic income, political theorist, he talks precisely of the need, the necessity of going beyond objectivity. And he talks in terms of a kind of almost infinite excessive responsibility as that kind of positionality.
Mm-hmm.
I think it's transformative for positioning oneself as an engaged academic, that it's liberating, but also it puts a very compelling burden on how one behaves.
Infinite excessive responsibility?
Yeah.
That sounds to describe the weight of such a burden substantially. Oh, no, I'd be very interested in looking more into it. Yeah, but I think it's hard to figure out how to move beyond the sense of it being crushing. Or then on some level, I mean, one of the things I continuously stress when talking about this new law is just how modest it is, right? So it does something. It is a success story in a sense that the pharmaceutical lobby opposed it. And again, this is the first time I've been specifically in an adversarial relationship with the pharmaceutical industry, rather than simply trying to create a space of observing than as an actor with their own rationality. And it passed. And yet it's still a small thing. When I think about the problem of drug prices in the United States or affordable medicines more globally, it's just a tiny piece of it. While working on this bill, kept on going back and forth between a sense of, well, here's a place where there's traction and we can actually do something, so let's do something. And then also feeling at the same time, what a small piece of a giant global problem, the large bulk of which we're still powerless to really engage with. And I think infinite excessive responsibility describes that latter feeling really quite accurately. And yet a sense that that actually engaging with that, opening it up, is both liberating, having a sense that our scholarship does something, and then immediately frustrating and realizing just how little any of us as individuals can actually do. I don't want to end on that particular form of pessimism. I mean, there's many forms of cynicism and pessimism that I'm happy to engage in, but I think that part of this effort, for me, part of where it's been sustaining is recognizing the value of having colleagues in different fields that feel equally frustrated by the small contributions their own scholarship can make, and yet by working together to catalog them. And another thing I might say on this is this group, this interdisciplinary group at Hopkins that formed to deal with problems of drug pricing, formed when we realized that several of us were having traction, that there was a moment now in which the issues of drug prices had reached a certain level of visibility, that rather than simply going away after one hearing, we're building moment by moment, crisis by crisis, and that something could be done. And we began to catalog the different kinds of levers that could be pulled if one seriously wanted to do something. But of course, it's a very different world after November, certainly after January, than it was when we began our collaboration last spring. And one of the parts that has been sustaining for us is recognizing that actually trying to pool together all sorts of different spaces that can be acted upon helped us from dealing with the overwhelming sense of powerlessness in a world that is changing really rapidly in ways that many of us find concerning. So one of the reasons my talk, rather than starting with the US and going global, starts with the US and then actually becomes very, very local to the state of Maryland, is that we began to realize that in the shifting structure of pharmaceutical policy right now, the local register was one which we could actually do more with. So, but this process of being with other colleagues who can point out to opportunities where your own work has worth and value is a really extraordinary thing. And it's something that you all offer to each other in this process. It's a bit more of a pep talk than the crushing weight.
That's worked very nicely. Dan, yes. Could I just go back to another question? I'm going to just go back to some of your answers, actually, to both of those questions, and to think about, you started off with uncritical histories.
Yes.
And I was thinking of some of the discussions about invented traditions, the disciplinary stories that we tell ourselves, and then began to wonder about the story that you told yourself, about yourself, to us. With the sort of, we're going away thinking you're a good doctor, but actually your answer to Alice suggested that, of course, there's a complexity to that, because you don't really know the outcome of the intervention that you've had because of the way that then the generic drug companies reshape themselves. And so, in a sense, my question is how have you shaped this history for a purpose?
Yes.
And what has this process done in terms of reinvigorating, changing your own historical stories, but also your own historical practice?
Yeah, so that's a question I hadn't actually thought of. It's a good one. And again, to repeat for the broader audience that it gets very meta very quickly. But the question, as I understand it, is how is the history that I've told you today of my own involvement as a historian in policy created a narrative that can actually reshape my engagement as a historian? And I've left it somewhat open-ended right now because we don't really know what the implication of this law will be. I think it has the potential to, at the very least, act as a deterrent to future Martin Shkreli's, that someone who wants to come along and see that there's a pathway to exploit the non-competitive market for an older drug might think twice now, knowing that they would actually face a very active Attorney General's office in the state of Maryland. It'll be interesting to see what the Attorney General does with it, because the first case that invokes this law will actually work to set precedents, and those precedents will be very important to Matt. the possibility that I still leave open for myself continuously is that everything I do may actually make the world worse rather than better, is something that I would like to model as a part of what history offers policy in general. And so there's a reflexivity in that, but there's a reflexivity that comes with acknowledging that when we engage with policy, we are not simply observers and social scientists, that we're actors, and we have a responsibility to that form of reflexivity, of actually monitoring what the effects of our own analytic or empirical or legal interventions are. I do think that for me in my own narrative, this has helped to reinforce the sense that as a professor of history, I do have the ability to engage, sometimes in powerful ways, within arenas of policy making, and that this is a field that we collectively should take seriously. We should step into it, but we should step into it while retaining that kind of self-critique that we would like to wish upon the actors that we've been describing so far. I think that's a very different place than I was 5 years ago, I would say. And it requires managing a certain level of discomfort and acknowledging the sense that our own actions may actually be deleterious as well as helpful, rather than simply assuming that by advocating humanism, by advocating culture, by advocating social context, we're necessarily performing virtue. We need to actually make sure that that is actually being communicated as it goes along.
Yeah, no, that's very nicely put. I mean, some nice lessons for us to think through as well in relation to the various senses that we're coordinating as well. And that sense of self-critique,
yeah,
I think, is crucial. The reflexivity that we want to build into the way we work, and the way we work as a process with partners, I think, is absolutely key to what we're trying to do both in the Wellcome Centre, but also the WHO as well. Are there any other questions, or shall we leave Jeremy to go and have a drink? And us. I mean, not just Jeremy.
Well, I would stress one more thing, which is that one of the things that I think all of us have is a sense of knowing the difference between good, rich, challenging historical investigation and this other bugbear that I didn't list initially of a pat history, right? A history that exists to support a preformed opinion, right? That part of engaging with this realm of policy is continuing to preserve a space for history to involve empirical contact with the unknown, in which our assumptions going in can be challenged and that we can be wrong. So this is how I want to evaluate what happens to the effects of this bill. That now that the bill is passed, I don't want to be its champion. I want to watch it, and I want to see how this intervention is actually acting. Now, whether or not I can disengage that easily, whether I may still be called upon to be that champion, that gets to the question that you were raising earlier, right? But it is essential that as social scientists that we continue, and humanists, that we continue to be able to engage in a space where we don't know the answers to the questions that we're asking. And I think that comes back to this point you're making, that there's this continued process of reduction in which our own work can be reduced. Maintaining that space of encountering the unknown, of realizing, and I think this is a fundamental difference between the kind of research we do in the humanities and social sciences and the kind of research that happens in, say, other arenas of policy, other arenas of biomedicine, is the sense that we're not merely testing hypotheses, that part of the research we do is finding the questions. And so maintaining that space, that part of research is getting to the place where we can even understand what the question is that we bring to the table. That's enormously valuable, but we need to preserve it. Anyway, but you've been patient with me long enough. So.
No, that's very nicely done as well, because in fact, some of that openness to being challenged yourself by the evidence came through in some of your, when you were describing some of the ways you've worked towards the arguments of the books, I think that came out very nicely. And again, it's, we could say that we want to embrace front uncertainty. Within the centre, all that means is we don't quite know what we're doing. Yeah. Actually, that's the risk. I'm sorry, Dan. Don't hear that. Don't hear that. But there is a sense in which we are looking towards emergent understanding, learning, and growing, and engaging in new ways, and that does produce uncertainty and being uncomfortable. Yeah. Sometimes with where you are and what you're contributing. So I think again that has come out very, very neatly about the, the intellectual rigor, but also the bravery of taking that line and doing that kind of work, I think, which has been very, very constructive listening to you. If there are no further questions and people would like a drink and something to eat, well, nibble rather than perhaps. Jeremy, thank you ever so much for.
Thank you so much. Very valuable.
Oh, thanks. And I hope we have recorded somewhere because there's a few paragraphs we need to put on our website.